Hello everyone, I am Fernanda Castro Ibáñez. I'm a med student here attending the Universidad Católica de Santiago Guayaquil in Ecuador. And you can follow me on Facebook by Fernanda Castro, on Twitter by @faircast999, and here we have a topic to talk about. So today we're going to talk about first the Nivolumab plus Ipilimumab in lung cancer with high tumor mutational burden. So first we have the definition. The definition is that lung cancer, also known as lung carcinoma, is a malignant lung tumor characterized by uncontrolled cell growth in tissues of the lung. And here we have a video to talk about it.
Lung cancer can start in the windpipe, the main airway, or the lungs. It develops when there is uncontrolled growth of abnormal cells inside one or both lungs. These cells grow to form tumours. More than 8 out of 10 cases of lung cancer in the UK are caused by smoking. If you're a smoker, quitting is the best thing you can do for your health. Passive smoking also increases the risk. Lung cancer is more common in older people and in people with previous chest problems or lung diseases such as emphysema. Other risk factors include exposure to radon gas, air pollution, and chemicals in the workplace. A cancer that starts in the lung is called a primary lung cancer, while a cancer that starts in another part of the body and spreads to the lungs is called a secondary lung cancer. The stage of a cancer refers to its size and how far it has spread. Doctors look at the size of the tumour, whether it is in the lymph nodes, and whether it has spread to another part of the body. A small cancer that is just in the lung is likely to be an early stage cancer. One that has spread into the surrounding tissue or to another part of the body is an advanced cancer. You can find out more information about lung cancer by visiting the Cancer Research UK website.
Yes, so if you want more information about it, you can visit that site web. So now we have the application in medicine, which is a Nivolumab plus Ipilimumab show promising efficacy of the treatment of non-small cell lung cancer, NSCLC, in phase 1 trial, and tumor mutational burden has emerged as a potential biomarker of benefit. In this part of an open-label multi-part phase 3 trial, we examine progression-free survival with Nivolumab plus Ipilimumab versus chemotherapy among patients with a high tumor mutational burden. So we have a video to try to explain this and also start.
I reviewed the results of the Checkmate 032 small cell patients treated with Ipilimumab and Nivolumab, and there's a lot of excitement around that because we see both response rates of the combination arm up to 20% but also if you look at the survival curves, the 2-year overall survival for the combination arm was 26% versus 14% for the Nivo only arm. Those patients are doing extremely well in terms of their median progression-free and overall survival, and doing much better than small cell patients do in general. So we're really changing the natural history of that disease. So that is something on the basis of that study. The combination has been added to the NCCN guidelines. So it's a strange situation where the drug combination is not yet FDA approved for that indication and yet has been included in the NCCN guidelines. So as a clinician, you're thinking to yourself, well, it's not yet FDA approved, but if I know that insurers will pay for it, is this a good option for my patients? Especially those who have responded to chemotherapy, who have not responded to chemotherapy or recur very quickly. And I think the caution there is that this is a toxic regimen. I think that it needs to be, the toxicities can be managed very well, but you really need to know what to look for, and you need to be careful in your selection of patients who can receive this regimen. But in general, it's a tremendous milestone for the field of small cell and for those patients that we have these new options, these new tools to use and develop. And then I spend a lot of time looking at different combinations of these new immunotherapy agents in combination with chemotherapy and so forth in the small cell space.
Okay, so nowadays we have the clinical essays and also the clinical trials to find the efficiency and also the pros and cons of this type of drugs. So first we have the pros. The positive things that is that it helps to control the growth of cancer cells. And the negative ones, which are the cons, that they are very strong and can have many side effects like enterocolitis, liver problems, etc. And here we have the video too, so you can see for yourselves. This one is very short and is by the same doctor. Just
the types of toxicities that you can have are similar to the toxicities that you have for either one of those agents alone or for Nivolumab. In that Checkmate study, about 70% of patients did have treatment-related adverse effects. If you manage them, many of them can be managed by steroids or by withholding the drug. About 10%, a little over 10% of those patients, the treatment needed to be discontinued because of those treatment-related adverse effects.
Yeah, so that's one thing. And now we have the issue applied in Ecuador, which is that between 2006 and 2010, the incidence rate of this cancer, the lung cancer, was 7.9 per 100,000 inhabitants of Quito. There were 261 cases in this period. And here we have, it was like very important here in our country. So we have a video here. I think it's by the same channel but different doctors, so listen.
When we talk about TMB, it does sometimes sound as if it's the separate test that needs to be sent, especially for TMB testing. But I think a better conceptualization of it is that it's additional data that we get from the routine molecular analysis that we should be doing of all patients with lung cancer. So that when we think about patients with lung cancer, we've increasingly started to visualize this pie chart of lung cancer. No longer just a big mass of a big sort of group of patients, but patients defined by distinct biology. And EGFR, ALK, RET, ROS, BRAF, those are all examples of where we've identified particular markers that identify specific therapies for those patients. And I think the TMB result that comes from the same sort of test, the same molecular profiling that we do to understand EGFR and RET and ROS and the rest, then brings a new piece of the pie that has a specific therapy that has exceptional opportunities for long-term benefit.
Yeah, so now we have the conclusion, which is that progression-free survival was significantly longer with first-line Nivolumab plus Ipilimumab than with chemotherapy among patients with NSCLC and high tumor mutational burden, irrespective of PD-L1 expression level. The results validate the benefit of Nivolumab plus Ipilimumab in NSCLC and the role of tumor mutational burden as a biomarker for patient selection. So that was it, guys, and thank you for being here. So see you next time.